question, what will we do in terms of our internet strategy? And we decided that really what we should do is to focus on the delivery of care. So when we did that, it resulted in building out this set of tools, and the first thing we recognized is that we were going to use the internet effectively. We had to think about building tools not only for the doctors and nurses in our hospital and physicians' offices, but also for patients, other providers that weren't part of our organization, payers. Everyone in the healthcare delivery system had to be part of that theory. So what you're seeing here is a whole set of tools that we have now built out. The MyChart personal health record is a tool that goes with every patient. You can use it anywhere in the world, and it gives you access to your health information that happens to be generated at the Cleveland Clinic. The MyConsult service is a service where any patient in the world, we do it now from 60 countries, who needs a second opinion and wants to get to one of our specialists can go online and do that directly without ever setting foot in Cleveland. The DR Connect service is for physicians who are not part of the Cleveland Clinic but may well refer a patient to us, and that happens over 150,000 times every year for individual patients going forward. And then we have the core thing that we've heard a lot about, which is the electronic medical record, which is the tool inside of the four walls of a physician's office or a hospital organization. So I just wanted to make sure you understood that those tools are really critical. Oh, great, thank you. And we have to move them forward. Now, I put together a little story, so I'm going to focus on one or two of these tools to make that happen. So the first one is this personal health record. So in Northeast Ohio, but you can imagine this is across the nation, we have facilities that are distributed not clearly as dense as Walgreens is, but a lot closer to where the patients live, and that's about 100 miles from left to right. Our key was to be able to enable that enterprise so that all of our physicians and all of our nurses could see the information well before a patient could go from one of those dots to the other. But we also recognized that that wasn't enough because we were surrounded by 3 million patients that didn't live in one of those gold circles, and we wanted to connect them as well. So in order to make that happen, we used that electronic medical record that everyone uses when you come to see the physician, and we extended that tool into the home over the internet through that personal health record tool that I told you about. So now we have any patient and any of our physicians connected all the time. So let me sort of close with how this story now works, and this is a chronic disease model, and it's a patient who comes into our organization and sees a physician. When they come in, or even before they come in, they can register for that personal health record tool and see their physician. Now they can go home and they can actually begin to use that tool in the digital age. So now I want to focus in on how are we actually going to transform the delivery of care. So the first thing we have to think about is we can care for that patient wherever they are, not where we are. And this tool allows us to do it, but what they need are some gadgets in order to make that work. And those are coming out very rapidly now. So if this were a patient with hypertension and diabetes, what you can see is we can give them a set of digital tools that are consumer-oriented that they can use by prescription from their physician to help monitor their own health. So they become active participants in the care, but they don't have to do the work of monitoring that. We can have the device do that. And what does the device do? It collects the information that's required accurately. It makes it available digitally, and under the patient's control, they can then decide to make it available to whomever they want. Now, connectivity is the space that's too large for the Cleveland Clinic. So about 2 years ago, we began thinking about if we can do it for 3 million people in Northeast Ohio, how are we going to do it for 10 million people? And clearly that would be our goal to get to that kind of scale, but for our patients wherever they are in the world. So we started to think about who are the big connectivity partners, and we worked with 2 companies to make this happen. The first was Google, and they announced a program with us that was initiated about 18 months ago that's called Google Health. From our perspective, it's a connectivity tool for that patient. They can go in, they sign up for the service. Google is in the business of connecting to individual practices and EMRs all over the country, a business I don't want to be in. One of the places that they connect to is the Cleveland Clinic, and so that patient can say, through that connection, I'd like you to pass my information under my direction to the Cleveland Clinic. We did a similar project with Microsoft just over a year ago, and I'm going to show you some early results of that right at the end. So connectivity is coming. It's another set of tools. It's got to be part of the infrastructure, and it should not be controlled by any one healthcare organization. Now the patient has directed that information to their provider. It arrives digitally. The physician isn't retyping it in. You can use the power of the tool so it knows what diagnoses this patient has. It knows what values should be coming back, and those values can be promoted to the appropriate provider in a timely fashion. If they're way out of whack, it probably should go directly to the physician. If they're within a certain range, it might be better managed by a nurse practitioner going forward. And if it's within the range, you can actually get the computer to send an attaboy back to the patient, letting them know without having anyone else involved in that cycle. Now, in this case, we're going to assume that the patient, in fact, was not well controlled, and we needed to do something about it. So action, changing the treatment paradigm, historically has required the patient to come back into the office. We have to get out of that mode going forward. So here the physician gets to see those results directly entered in digital form, actionable, right in the context of the rest of that patient's electronic medical record. They can then make a decision that they need to communicate, so they're using that personal health record tool that I told you about to talk to their patient wherever they are. So in this case, this patient actually needed to adjust their blood pressure medications. That was communicated. It came directly from their physician. That patient knows the physician has all of the information, including the information that came from their home, that's available to them. And so now that treatment plan gets changed today rather than a week from now or a month from now when I could get that next physical appointment. So then let me close this story then by saying, as we bring this together, this is what we mean by transforming the practice model of care. We've got to eliminate the idea that everything must happen in one physical location. So quick summary in terms of results. We took 250 patients over the course of a year, and we ran them through this program for hypertension, diabetes, or heart failure. Based on what they had, they were given one of those 5 gadgets that you see there, more than one in many cases. For heart failure patients, they actually had 4. For hypertensive patients, they had 1. Diabetic patients had 3. And we gave them those tools, and we began to manage those patients at a distance. So what did we find? We found a couple of things. One, patients found real value in terms of increasing the relationship with their physician, because now they had that relationship and it felt more like 24 hours a day rather than once a month or once a year. The second thing is it was actionable, so what we looked at were their hard clinical parameters. Was their blood pressure still under control or better? And in this case, we were able to accomplish that. And then what you're seeing here is that the interval between appointments went up dramatically, which is a good thing. So they didn't have to come into the office nearly as much. That's good for the patient. It's more convenient.